Hi class. So this is chapter 22 on pancreatic disease, and we're going to go a little bit as overview of the pancreas. So it is located below the stomach and above the transverse colon. It is composed of both endocrine and exocrine tissue, and it's important to make those distinctions. The exocrine cells are the acinar cells, and they produce the enzymes that are essential for digestion. And the endocrine cells are your alpha and beta cells, also known as the islet of Langerhans for the beta cells. And so there's alpha and beta cells, and there's little islands of these cells all over the pancreas. Now, I do want to note that like about 98% of the pancreas is devoted to the exocrine, the digestive. So they're the acinar or acini cells, and they make amylase, lipase, chymotrypsin, and all of those enzymes that are going to digest, go into be secreted and digest, and they make also the high bicarb fluid and all of that. And then dotted around in little islands all around the pancreas are your alpha and beta cells. So your beta cells are the islets of Langerhans, and they produce insulin. And then the alpha cells produce glucagon. And insulin reduces the amount of glucose in the blood, and glucagon increases the amount of glucose in the blood. So what insulin does is usually insulin kicks in after a meal. So somebody's eating a big meal, being digested, the glucose is crossing over into the bloodstream, and the insulin is released so that the glucose can be brought into the cell. So the insulin would bind on the insulin receptor and bring the glucose in, therefore lowering the amount of blood glucose in, the glucose in the blood. And then glucagon increases glucose levels when you are not eating or when you've been fasting for a certain amount of time, and your blood glucose levels start to drop, and you need to maintain them. So it usually triggers usually it's glycogen is broken down to increase glucagon. I'm sorry, to increase glucose levels. So, all right, let's talk about pancreatitis. So it's a common condition, and it's an inflammation of the pancreas. And so if you think about it, the digestive enzymes that are produced by the pancreas are made to digest protein, and the cells and cell walls have protein in them, and so the ones specifically that digest protein usually are released as a zymogen in an inactive form and are activated once they hit the small intestine. But what happens if they get activated while they're still in the pancreas? Well, what happens is they start digesting the pancreas, and that's not a good thing. And so basically you have the normal digestive enzymes that are supposed to digest food stuff are digesting the pancreas. Acute pancreatitis often resolves itself, and chronic pancreatitis is usually the result of long-standing damage. So in this picture here, you can see that there are like gallstones showing that blockage. So yeah, stone formation can cause blockage of these ducts and keep these enzymes from flowing and all that, and then causing pancreatitis. All right, so let's get a little bit more on acute pancreatitis. So one of the hallmark of acute pancreatitis is, it's strong pain. It's abdominal pain that you can't ignore. It's really severe. You can have fever, nausea, and vomiting also with it. And if it is not taken care of, it can be life-threatening, and it can cause massive hemorrhage. The most common causes of acute pancreatitis are gallstones, as was shown in the picture before, and heavy alcohol use. So this is very prominent among alcoholics. And when we talk about alcoholics, we're talking about people that, use a lot of alcohol like every day. So like one of my patients used to say, like he had admitted to that. He was like, well, I used to drink a fifth of whiskey a day. And so he had chronic problems with acute pancreatitis, and then eventually chronic pancreatitis. To diagnose acute pancreatitis, you would need to do amylase and lipase. And amylase is always more specific to the pancreas because it is produced by the pancreas, whereas amylase can be produced by the pancreas and by the salivary glands. So that's why lipase is simply more specific for pancreatitis. And so, yeah, if you had mumps, you could have elevated amylase, but it would be due to salivary amylase. And most of the assays that are there are just detecting amylase, and they're not differentiating between pancreatic or salivary. But if you have amylase and lipase that are both elevated, then you can pretty much bank basically on it being acute pancreatitis. Okay, so for chronic pancreatitis, it's a pancreatitis that progresses over time. So they have it usually anything chronic is 6 months or more. It can lead to permanent damage, and again, same cause, persistent and heavy alcohol use. So they can go from acute pancreatitis to chronic pancreatitis, and then from there they can become diabetic and also have pancreatic insufficiency. So diabetes is, from the damage to the pancreas, then there's a problem with insulin secretion and stuff due to the chronic pancreatitis. But the pancreatic insufficiency is referring to the lack of the digestive enzymes, so they're not breaking down the food properly, which then means they're not able to absorb all the nutrients that they need. And I will tell you, one of the things with these, think heavy alcohol use, these are people that have more like addictive personalities, and the chronic pancreatitis is painful. And so they tend to also become chronic pain pill abusers. So they come in with flare-up of pancreatitis and they want their pain medicines, and they're pretty much, a lot of them are addicted to pain medications also. Not saying that this applies to everybody, it's just kind of a pattern out there. So we diagnose them. The blood tests are not as helpful as in acute pancreatitis, because in acute pancreatitis, these levels are going to up significantly. So in chronic, your amylase and lipase can be normal. The trypsin levels, which is one of the enzymes that digest proteins, they're relatively specific, but you don't see the decreased concentrations until the disease is well advanced. So they've had to have chronic pancreatitis for a while to where they've developed quite a bit of pancreatic insufficiency, and then their enzyme levels drop. You can do functional test. The secretin test is very sensitive, but it's invasive and only specialized institutions do it. And or there's a testing that requires the patient to take an oral dose of a substance that is hydrolyzed or broken down by the pancreas, and that substance is then measured in serum or urine. So basically, like, think of it, if we did a starch that's labeled, and the pancreas is supposed to secrete amylase to break down the starch and release the sugar, and that should be labeled and stuff like that. If they're not producing the amylase to break it down, then the starch never gets broken down and never gets absorbed as a sugar, and then it won't show up in the serum. So that's kind of the idea there. All right, so let's talk diabetes. So diabetes is very, very, very prevalent in society, especially in the US. And diabetes is a malfunction of the endocrine portion of the pancreas. And you have type 1 and type 2 diabetes. So type 1 was called juvenile diabetes. It is insulin-dependent diabetes mellitus. So people that have type 1 diabetes have to have insulin. It's not an option. And it is autoimmune in nature, where there's a trigger and there's an autoimmune reaction, and the antibodies that are produced attack and destroy the beta cells, islet of Langerhans, and so all the beta cells are destroyed, so their capacity to produce insulin goes down to like 0, and then they can't get the sugar inside the cells, your glucose inside the cells. All right, for the type 2 is called non-insulin dependent diabetes mellitus. Although once they've had type 2 for a long time and have severely damaged their pancreas, they can produce to needing insulin, but at the onset, they do not need insulin. It used to be called adult onset diabetes, and it is lifestyle related. So this comes from there's a genetic component to it also, but this comes from a lifetime of just poor diet, drinking a lot of sodas, eating junk food, not exercising. Just basically, if you eat the standard American diet, it just sets you up for diabetes. And it's not, unfortunately, this is a sad commentary, it's not really called adult onset diabetes because our diet has gotten so bad that we are seeing children that are developing type 2 diabetes and that are overweight and stuff like that. It is also possible for adults to develop type 1 diabetes. It's rarer, but it's possible. So let's talk about a case here. I'm going to move my little camera down. So John is a 19-year-old college student with flu symptoms. He goes to the ER with headache, muscle aches, and fatigue. And no, he does not have coronavirus. His lab results are a glucose of 800 milligrams per DL, a sodium of 120 milliequivalents per liter, a potassium of 2.9, a chloride of 92, and a 3+ acetone level. What is the likely diagnosis and what causes this disease? So from everything that you see here, what we're going to note is that it is more likely for him to be a type 1 diabetic. So you have hyperglycemia, so you have a really high blood sugar right here, okay? And that could be type 1 or type 2. Okay, that's totally possible for both, although they can both, they can both get crazy levels. So hyperglycemia, and it is definitely in the diabetes range because it's 800. And we're going to talk about cutoff values and all that here in just a minute. So sodium, potassium, and chloride are all low and basically show loss of electrolytes and dehydration and stuff. So this would happen because the body's going to try to flush out that glucose through the urine, and it's going to flush out with a lot of the water, and the electrolytes are going to go with it. All right, because of there's so much glucose that your serum has a very high osmolality and is very concentrated, and it needs to try to dilute it down. And anyway, so it's going to try to get rid of the glucose. And the acetone here is 3+. This is the one key indication that this would be type 1 diabetes. So acetone is the same as ketone. So in ketones are an indicator that because he cannot burn glucose as fuel, he's burning fat as fuel. So when you burn fat as fuel, you make ketones. And you can detect the breakdown, the ketone bodies and stuff. You can detect those in the blood. And since even though his blood glucose is really high, there's no glucose getting into the cells, so he's burning fat. So because there is absolutely no insulin present, you would see the acetone, the ketone levels rise. In a type 2 diabetic, it's a pattern of insulin resistance, not lack of insulin. And so the receptors simply are not responding to the insulin as well, but they respond some. So some glucose gets into the cells, and that's enough really to suppress lipolysis and to not cause the ketone to show up. So we would go with type 1 diabetes here in John's case. And what causes this disease? It's an autoimmune reaction. They think that it's linked to just a viral infection, and then the immune system kind of gets mistaken and thinks the pancreatic cells, the islet cells, are a virus and attacks it and destroys it. Okay. So let's dive into type 1 diabetes again. So you get the beta cell destruction of the islets of Langerhans. You get insulin deficiency, no insulin production at all. Insulin is a hypoglycemic agent, so that means it lowers blood sugar. It doesn't mean it kicks in when you have hypoglycemia. Do make that distinction, okay? So insulin kicks in to lower blood sugar. The major effect of insulin is to promote the transport of sugar across the cell membrane of fat and muscle cells. So your fat and muscle cells can use the sugar, the glucose, to make ATP. Okay, and so that's its major effect. It is also considered a storage hormone because once you are full up on glucose, it's going to make sure that all the excess gets stored. So high insulin levels tend to lead to weight gain, especially fat, because it will help make all of the sugar into fat and store it up. The autoantibodies will be present, so it's the T cell mediated destruction of the beta cell. So it's this, the cytotoxic T cells so cellular immunity. And so there are some autoantibodies you can test for that would be positive if the patient has type 1 diabetes. The symptoms are the same symptoms as type 2, except for the weight loss. So polyuria, so peeing a lot, polyphagia, eating a lot, so they're hungry, and polydipsia, thirsty. They're drinking a lot, and then they have weight loss and fatigue. So the weight loss is a hallmark of type 1 diabetes, and that's because they're not getting the glucose into the cells, and there's no insulin, and the insulin is your storage hormone. So we have a loss of all of that, and so we'll have weight loss usually. Type 1 diabetic patients tend to be skinny. The polyuria and polydipsia, so your excess thirst and excess urination is from the really highly concentrated serum from the high glucose. So high osmolality triggers the thirst centers in a hypothalamus, because your blood is perceived as being really concentrated because there's a lot of sugar in it and it needs to be diluted. So you get really, really thirsty, and then you'll be peeing a lot because it's trying to flush the excess glucose. And in polyphagia, like, why the heck would you be hungry if your blood sugar is 800? Is because the hunger signals come from your cells, and your cells are starving because the glucose is not there. It's outside the cell, it's not inside the cell, and so they're sending the signal of, please feed me, we have no energy, we're dying here of hunger, when in fact there is plenty of glucose, they just cannot get in. So this is another thing that's interesting. The absence of insulin does result in an excess of glucagon. So because the cells are sending that signal that they're hungry, including the liver cells and all of that, the liver is like, I'm going to help you and send you plenty of glucose. So it starts to break down the glycogen in releasing glucose. And so that's, and it even goes to gluconeogenesis to increase the blood glucose. So that is adding fuel to the fire. So that blood sugar is climbing and climbing and climbing and climbing. And so, again, the lipolysis and the ketone production happens inside of the cells because the glucose is in the bloodstream and it's not getting into the cells. And so, the insulin normally stimulates lipogenesis, so the making of fat, and inhibits lipolysis, which is the breaking down of fat, but insulin is not there. So absence of insulin means you would get lipolysis, so the fat is going to be broken down and burnt and stuff, and so again, the lack of insulin does lead to weight loss. And you have the production of ketones, which is a hallmark of type 1 diabetes, especially in the acute phase, because you are burning fats. You have the lipolysis breaking down the fat to produce ATP, and the ketones are a sign of that. And so if they have a lot of ketones, it can go into diabetic ketoacidosis, because the ketone bodies can be very acidic, and so then that starts messing with their pH and causing a metabolic acidosis from an excess amount of acids, which are the keto acids that are showing up into the blood. Okay, so then let's go to type 2 diabetes. Okay, so this is our Homer with his big old belly and eating his donuts. So there you go. If you want a poster child for type 2 diabetes, Homer Simpson is definitely one of them. So it is a spectrum of disorders. It is chronic disorder. It develops slowly and kind of sneaks up on you. So you will see insulin resistance, so it's impaired insulin action. So the insulin is not docking on its receptor properly. That's not working. And so if you measured insulin levels in a type 2 diabetic patient, you would see high insulin levels. If you measure insulin levels in a type 1 diabetes patient, you would see low insulin levels. Okay, so that gives it it has high insulin levels but low insulin action in type 2 diabetes, so it gives it a relative insulin deficiency, meaning there's simply it's not working and it's not enough to get all the sugar inside the cells, so the blood sugar levels, blood glucose levels start to rise. And then if that keeps going on for years and years and years and years, these poor beta cells are constantly having to produce a bunch of insulin to try to make up for the lack of activity, then they basically get tired out. And you end up then with a defect of insulin secretion, so then their insulin levels will start going down. That's when then your type 2 diabetic patients will need to start taking insulin. Okay, so risk factors for type 2 diabetes are abdominal obesity, again, little Mr. Homer with his big old guts, sedentary lifestyle, so sitting a lot, you know, just not being active, not exercising on a regular basis, having a desk job, having hypertension or high blood pressure, having elevated triglycerides and low HDL levels. And all of those factors taken together are also what we refer to as metabolic syndrome. So the symptoms of type 2 diabetes are obesity, dyslipidemia, so again, the elevated triglycerides, low HDL, high LDL, all of that, hyperinsulinemia, so high insulin level in the blood, hypertension, so high blood pressure, fatigue, itching, recurrent infections, visual changes, because it does affect the capillaries in the eyes and stuff, numbness and tingling and weakness. So that causes also nerve damage. And so they have a bunch of stuff that goes with it. Type 2 diabetes is 90% of our diabetes cases. 10% are type 1, 90% are type 2. So 90% is lifestyle mediated, and if you do some research about it, you will also find that if you modify your lifestyle, and this is not too advanced, it is very possible to come off of insulin if you've been on insulin and to actually get back to normal sugar metabolism and everything. So it is possible to cure type 2 diabetes with lifestyle changes and diet changes and stuff. It takes some drastic changes, but it is totally possible. So you won't see ketoacidosis in type 2 diabetes because even though enough glucose gets into the cells, enough glucose gets into the cells enough so that you don't get the ketoacids. It suppresses the lipolysis. So usually you do not see ketoacids in type 2 diabetic patients. And they can get something called HHNKS. It's called Hyperglycemic, Hyperosmolar, Nonketotic syndrome. So it's almost like their equivalent of DKA, where they get really, really sick. And so they have high blood sugar and then a highly concentrated serum, but there are no ketones, and they can get severe dehydration and all kinds of problems from that. So this little chart shows a little bit about type 2. So there is definitely a genetic factor, but that's not the only thing. So you take the genetic factor and then you add diet and activity, and then between those two leads to obesity. And then when you have obese people or a person is obese, you will have an increase in free fatty acids floating around. You will have adipokines and inflammatory cytokines that are floating around, and a decreased activity of ghrelin. Ghrelin is a hormone that tells you that you are full and you don't need to eat. So that if there's a decreased activity of that hormone, then you're hungry all the time. And so you eat more and all of that, and that means you gain more weight. You develop insulin resistance from all of these things present, and the inflammation, adipokines, and all of that. You start getting a decrease in beta cell mass and beta cell function. And so when you're in insulin resistance here, you'll have hyperinsulinemia, and you get tissue, you can get tissue effects. I'm going to move this. Without hyperglycemia, so it is possible to get insulin resistance without diabetes. So the sugar is damaging to your body, but the insulin is damaging to your body too. Having high insulin all the time is actually bad. So you get insulin resistance without diabetes, or that's what can happen if you just have high insulin levels. So sometimes some people are told that they're pre-diabetic. So usually their sugar is not high enough to be considered diabetes, but their insulin levels are up. That is a sign that they're on the pathway to becoming a person with type 2 diabetes. Okay, and so if they modify their lifestyle and changed, it could reverse it. But this can then progress to this lack of beta cell mass and beta cell function, and then you have decrease of the insulin production, and then now you start getting tissue effects and hyperglycemia of type 2 diabetes, of the high sugar and all of that, and the damage of the eyes and the nerve tissue and all of that. You also have increased glucagon because you don't have enough insulin. So there you go. So what are all the different consequences and effects of, so we have causes and then consequences here for chronic hyperglycemia. So usually this would mean for type 2 diabetes. So, so if you have neurotransmitter dysfunction in the brain, altered insulin signaling, and altered lipid sensing, so this is really interesting. So your body is always taking inventory of the amount of fat that you have, and if that signaling is disrupted or doesn't work, so they're saying in a lot of people that have chronic hyperglycemia, this is not working, and basically your body, even though like you could be like 100 pounds overweight and your body thinks that you're starving and that you're underweight and we have no fat storage, and that we need to eat more. So that that drives the behavior of eating and stuff. So in the muscles, you start seeing decreased insulin sensitivity and decreased glucose uptake and increased lipid accumulation. And so then that can lead to chronic hyperglycemia. In the kidneys, you can see increased glucose reabsorption and gluconeogenesis. In the digestive system, if you have decreased GLP-1 and GIP, which transport glucose, and decreased stomach secretion of ghrelin, all of those, then the ghrelin, remember, is the satiety hormone, so it makes you eat more, hungry all the time. In the liver, you get more gluconeogenesis driven by glucagon, and again, that adds glucose into the system. In the adipose tissue and the fat, you get decreased insulin-dependent glucose uptake, increased lipolysis, decreased adiponectin, and increased leptin and resistin. And the leptin molecule is the molecule that goes and signals back to your brain to tell it that you have enough fat storages. And some of this, you can basically, just like you can develop insulin resistance, you can develop leptin resistance, where the brain is not responding to the leptin signaling, and it thinks that you're skinny and starving and that you need to eat more. And then you get macrophage accumulation and inflammation. So having too much fat tissue is inflammatory to your body. And then in the pancreas, you have decreased beta cell insulin and amylin secretion and increased alpha cell glucagon secretion, which we had talked about. All of that leads to chronic hyperglycemia, and of course then the consequences are retinopathy, cataracts, neuropathy, hypertension, peripheral vascular disease and stroke, heart disease, steatohepatitis and biliary disease. That means fatty liver disease, and biliary disease would be like gallstones and stuff like that. Gastroparesis means that the food in this is not moving through the stomach very well. So gastroparesis there, and nephropathy and glomerulosclerosis and chronic kidney diseases all affect the kidney from the high sugar all the time. You get oxidative stress, immunosuppression, infection, and cancers in the blood, and you get decreased cognition. So that can lead to like diseases like Alzheimer's, which has been going to be like Alzheimer's is like diabetes of the brain, basically, or type 3 diabetes is what they're calling it. So how do we diagnose diabetes? This is the business that we're in. So the diagnostic criteria are the same for type 1 and type 2 as far as the glucose is concerned. So any fasting glucose is above 126 is considered cut off for diabetes. So if you're above that, you have diabetes. And then on top of that, if you have the symptoms of polyuria, polydipsia, polyphagia, and unexplained weight loss for type 1, or chronic weight gain for type 2, and a random glucose of greater than 200 milligrams. So if they did an Acute check on you, or just you went to the doctor's office and they drew your glucose and it was like 250, you would be at the cutoff, above the cutoff for diabetes. The 2-hour glucose tolerance test should be, so this is a glucose after, drawn 2 hours after dose, a standard dose of glucose, that sweet stuff that I had you guys drink at the beginning of the semester. Yeah, it's like a really concentrated soda, basically. If the 2 hours after that dose, your sugar is still above 200, then that's considered diabetes. We rarely do that test anymore. They just do it for pregnant women. If your hemoglobin A1C is above 6.5, that's considered diabetes. And they can do autoantibody levels for type 1 diabetes. The islet cell, anti-GAD65, and anti-insulin antibodies can all be run to help diagnose type 1. So there are other types of diabetes. Some of them can be secondary. So from genetic defects, hereditary hemochromatosis causes damage to the liver and can lead to diabetes. So that one is, again, has a genetic component that's just different. Hormone diseases like Cushing's, because in Cushing's disease you produce excess amount of cortisol, and one of the jobs of cortisol is to raise glucose. And remember, cortisol, well, we haven't learned this yet. Cortisol, we're going to learn after spring break, is a stress hormone, and when your body perceives stress, it perceives that you might need to fight something off, and you therefore are going to need glucose, energy, ATP, right? And so it will raise your glucose. And so if you have Cushing's disease, where you're chronically producing too much cortisol, you will also have chronically high blood glucose level, even if you don't ever eat any sugar. So, and then of course you have gestational diabetes. Gestational diabetes occurs during pregnancy. If you develop gestational diabetes, which is having high blood glucose while you're pregnant, you are at a greater risk of developing type 2 diabetes later. Now, usually what happens is if you have gestational diabetes after you delivered a baby, things go back to normal, but you could develop type 2 diabetes later. So they do a glucose tolerance test for the pregnant mamas. If the fasting glucose levels are above 95, the 1 hour post-dose is above 180, or the 2 hours above 155, they're considered to have gestational diabetes. So another complication of diabetes can be hypoglycemia. So that is a plasma glucose of less than 55 milligrams per DL. And it is usually the result of insulin injections. So if a patient is on an insulin pump or an insulin injection and they take their insulin but then they don't eat, then that can cause problems. And so this is where like patient education can be really, really, really important. So this happened to my grandpa, and he was not type 1. He was actually not on an insulin injection, but he was on like the oral medications to lower blood sugar. And he had an appointment with a doctor, and they said, come fasting, we need to draw lab work. I didn't tell him anything else, so he took all his medications, including his blood glucose lowering medications, and he did not eat his breakfast. And he drove in Memphis traffic, and he didn't show up at the appointment, and they were like, this is weird, he's never late, he's always there. So they went out in the parking lot and found his car and found him passed out in the car from a really, really low blood sugar, because they didn't tell him to not take his medications either. So sometimes patients don't know, education is really important, but anyway, so, or maybe they get sick or something like that and throw up and all that, and they've had their insulin, but then they're not, their food doesn't get absorbed. So that could be a problem. So hypoglycemia can be a complication of insulin injections. So there are neurogenic symptoms, so tachycardia, so fast heart rate, palpitations, again, feeling like your heart's skipping a beat and you're shaking, all that. Diaphoresis is cold sweats, tremors, shaking, pallor, they're looking pale, and anxiety. And then some of the glycopenic symptoms also going along with it are headache, dizziness, irritability, fatigue, poor judgment, confusion, visual changes, hunger, seizures, and coma. If you've ever seen somebody that's hypoglycemic, it's really bad. They could appear like they're drunk, but they're not. They're hypoglycemic. So severe hypoglycemia can lead to death because you have no sugar to produce ATP, so you're not making ATP, and if you don't make ATP, you end up dying. Normally the brain needs glucose to function, but it can be trained to use ketones, but it does take a little bit to adapt your brain to burn fat. So your heart can burn fat also, but you know, if it's used to glucose and your glucose drops all of a sudden, then you get all these neurogenic symptoms and glycopenic symptoms, and it's not good. So another complication, so let's talk a little bit more about diabetic ketoacidosis. So again, this is a complication of type 1 diabetes, and it is life-threatening. So basically, the low insulin levels can lead to gluconeogenesis and ketogenesis. And so why would they have low insulin? So first, that could be on presentation. So they haven't been diagnosed yet, and this is their first time show up in ER, and they're usually come into diabetic ketoacidosis. Other could be simply non-compliance, or they can't afford their insulin, which is really, really sad. But so low insulin levels lead to the gluconeogenesis and ketogenesis. So that means they are making more sugar from protein and fats, and they're burning fat as fuel. Okay, so their blood sugar level is going to go up. The ketone bodies, keto acids, are going to go up too. Okay, and so the insulin deficiency leads to lipolysis, which increases the free fatty acids, which are delivered to the liver and can be burned for fuel, and those lead to the production of acetone, which is one of the ketone bodies, and that is acidic. Insulin deficiency also leads to excessive glucagon because cells are starving, and then it's going to make more sugar and stuff like that, and so it's going to release more free fatty acids, acetoacids, and beta-hydroxybutyric acid from the breakdown of those free fatty acids. So that's those are the ketone bodies we're talking about. Again, this develops really quickly, often in less than 24 hours, and has to be treated really, really quickly. All of these acids being dumped into circulation leads to metabolic acidosis because ketones are acidic. So you would expect a low pH with a low bicarb is what you would expect. This is a metabolic acidosis. Okay, so again, here it is, decreased insulin secretion or increased insulin resistant cells. So here we are, decreased insulin secretion. So you have decreased glucose transport into the cell. So then what happens, we have glycogenolysis. The glycogen is broken down, and gluconeogenesis, which raises your blood sugar. You also get really hungry, polyphagia, and you get also lipolysis and ketone bodies because we're going to burn fat as fuel. The ketone bodies are ketoacids, and then you get ketoacidosis and then ketones in the urine. The ketoacidosis leads to acidosis. And then the glycosuria comes from the hyperglycemia. Too much sugar in the blood spills over into the urine, which causes osmotic diuresis, large volumes of urine, which then makes you thirsty and makes you dehydrated and gets you an electrolyte imbalance. So you can see how all of those things, if you put all of that together, can be life-threatening really, really quickly. So the symptoms of diabetic ketoacidosis are polyuria, dehydration, the small respirations, which are rapid, deep, labored breathing. And why is that? It's because the body is acidic and it's trying to get rid of all the acid as CO2. And so you can have labored breathing like they've been exercising, except they have not been exercising. They will have dizziness when standing, central nervous system depression, so they can go into a coma. Anorexia, they don't want to eat, nausea, vomiting, abdominal pain, and thirst. Okay, so all of that comes together. And when you draw the blood, run the lab work, you will see a plasma glucose above 250, a decreased sodium, phosphorus, magnesium, and a really low potassium, a decreased bicarb, usually less than 18, and a decreased pH, less than 7.30, positive plasma and urine ketones, and an increased anion gap are all the hallmark lab work of diabetic ketoacidosis. Okay, so the other complication we mentioned, hyperosmolar hyperglycemic nonketotic syndrome, also known as HHNKS, being a complication of type 2 diabetes, so you're more likely to see this one than you are to see DK, but you are going to see both. I promise you, you will see both in practice. And so what would happen, what would cause patients to go into have this complication if they're type 2 diabetic? So non-compliance is always, that's one of them. So they're, they're not sticking to their diet, they're eating junk food, ice cream, and whatnot. And certain medications can trigger it, and then infections. So sometimes a patient that's very well controlled and very compliant, when they get sick, they can develop like a diabetic crisis, which is a HHNKS. So the insulin that is present prevents the excess fat metabolism, but your glucose levels can get extremely high, and you get a massive loss of water and dehydration. So you won't see ketone bodies. That's why it's a non-ketotic syndrome, but you'll have that hyperosmolar syndrome, serum, because it's hyperglycemic, because the glucose is so high that, again, it's going to try to flush it out, and you get a massive loss of water from that osmotic diuresis, and you get that dehydration that develops really, really quickly. Mortality is really high from this one. And so these guys can have glucose levels above 750 with increased serum osmolality, but their pH will be normal and the bicarb will be normal, because the ketones aren't present, so this is not an acidosis. We're not worried about that. It's just a really bad dehydration is what this one is. So these are general complications of diabetes, but especially type 2 diabetes. So we have a stroke or brain bleeding, we have cataracts, retinal microaneurysm, hemorrhage and exudates, all that for the eyes. For the heart, we have atherosclerosis in the coronaries. We have glomerulosclerosis and damage, kidney damage. You can develop chronic kidney disease. And then they can also have atherosclerosis in these main, like the femoral and the main arteries, so leading to bad circulation in the legs. They can get gangrenes in their toes and all that from the lack of circulation, but then also get neuropathy, infections, and all of that kind of stuff. So they're definitely quite complicated and have a lot of complications that happen to them. So the measurement of glucose. So let's talk a little bit about the measurement of glucose. Very critical in diabetes. So glucose can be measured in blood, serum, plasma, urine, and body fluids. It is worth noting, you need to remember here that whole blood is going to be 10 to 12% less than serum, and that's because of the volume that the red cells take up. Okay, so you always know that there's going to be a discrepancy. This is really important to know, because oftentimes what happens is your nurse will have a Acute, so a finger stick glucose that's done on whole blood, and it will read a certain number, and then you run it on serum and your number's not going to agree exactly. It's going to be 10 to 12% off. Okay, and so if it's on serum, if you actually draw blood out of an arm, spin it down, and run it on the big machine, it's going to read higher than what the whole blood reads. So the Acute rate. So you do want to separate the cells from serum and plasma, so you can use the serum separator gels for that, or simply pull off the serum or the plasma off of the cell and put it in a separate tube. Or you can use sodium fluoride, the gray top tubes, because they inhibit glycolysis. So what happens is the red cells undergo glycolysis, so they're still using the glucose, and they're just sitting there, metabolizing the glucose. So as your sample sits, if you don't separate the cells from the serum and the plasma, your glucose level is going to drop by 5 to 7% for every hour that it sits. Okay, so the hexokinase method is the first methodology we're going to look at. It's considered a gold standard in glucose testing, and what that means is that it's the method against which all other methods are compared to. It has the highest specificity to glucose. It's basically the most accurate. It's also more expensive. It is a coupled enzyme assay, and it uses a hexokinase enzyme. That's why it's called hexokinase method. And so if you look at a reaction, your glucose reacts with ATP and the hexokinase enzyme brings them together. So glucose and ATP. Hexokinase works on glucose because glucose is a hexo 6 carbon sugar. Hexokinase 6 carbon sugar. There you go. Turns it into glucose 6 phosphate plus ADP. The glucose 6 phosphate then is going to react with the G6PD enzyme and make 6-phosphoglucuronate, gluconate, sorry. And that reaction is also going to take NADP plus or NAD plus and make NADPH with hydrogen ions or NADH. And what you measure is the NAD to NADH or NADP to NADPH. And basically the amount of this that is produced, NAD or NADPH, is be proportional to the amount of glucose that was. So basically for every molecule of glucose, you get a molecule of NADPH or NADH. So you can measure the amount of NADH and then from there deduce how much glucose was in the sample to begin with. Then there's the glucose oxidase method, and this is another coupled enzyme assay, and it uses a glucose oxidase enzyme. That's where the name comes from. It is subject to interference by high levels of bilirubin, uric acid, and ascorbic acid, which is vitamin C. And they would all cause falsely decreased readings. Okay, so this glucose method is also cheaper, which is usually why it's used more, but the reference method is glucose hexokinase. So with this one, glucose and water and oxygen react with glucose oxidase, which creates gluconic acid and 2 hydrogen peroxides. And then the hydrogen peroxide reacts with this O-dianiside, which is basically a color indicator, and the peroxidase, and you get this oxidized O-dianiside and water, and this is a colored reaction, and it is proportional because for every molecule of glucose you get one of those, and so you have a color change proportional to the amount of glucose. So here you go. And next we're going to talk about glycosylated hemoglobins. So what happens is as the sugar is present in the body, it basically tags onto the hemoglobin molecule, sticks to it, and then it doesn't let go. It's a reaction that does not require an enzyme, so it happens in everybody. And it's also irreversible. So once the glucose is bound to the hemoglobin molecule, it is not letting go. And so we can measure this. And it does reflect a 2 to 4 month average glucose measurement, and that's because 2 to 4 months is the average lifespan of red cells. And we know a red cell is 120 days, and so you have to account for turnover and all of that. So to say 2 to 4 months is about what you can expect it to show. So high performance liquid chromatography is your gold standard, but that's not what's done in the labs, but it's what the other methods that are developed are compared against. Immunoassay and colorimetric assays are all available for A1C testing. Methods should be traceable. Patients who have conditions that affect red cell survival should not be monitored this way, because guess what? Their red cells don't live to be 120 days. They get turned over faster, which means that as the red cell gets turned over, the A1C gets broken down, and so it's not reflective of the 2 to 4 months. So that's not an accurate measurement for them. So if they have hemolytic anemia of some sort, or some kind of condition, or sickle cell anemia and all that, you wouldn't be able to use A1C to monitor them. The fructosamine is a different way to measure. It's another type of glycosylation that happens, but this one is only looking at 3 to 6 weeks of glucose measures, and so it's with fructose sticking to an amine, a protein, and the interference are alters serum protein levels, low hemolysis, lipemia, icteria, uricemia, so high uric acid, and heparin. So I know I mentioned like the glucose and fructose can stick to the proteins like hemoglobin, but it also can stick to like albumin and other things like that. We just choose to measure the hemoglobin. So, and then you have the oral glucose tolerance test, which I mentioned, which we don't really do for regular diabetes, but we do more for type 2 gestational diabetes. So it has to be performed correctly. So the procedure for the oral glucose tolerance test is a patient has to come in fasting. And it's better usually if they actually ate high carb the days preceding. Okay, so they fast overnight and they come in and you draw a fasting level of blood glucose, and then you give them a loading dose of 100 grams of glucose, and they drink that really sweet, icky, nasty, sweet drink. And then you monitor the blood sugar. So usually they can draw it at 30 minutes, an hour, 2 hours, 3 hours. Most of them are 3-hour length. Sometimes they'll do the 2-hour one, and if it's abnormal, they'll do a 3-hour one. And so a normal reaction is, as you see in this diagram, so after the dose, yeah, it is normal for your sugar to climb, as we saw in the lab earlier this semester, and it would climb almost into diabetic levels. And then, but within the second hour, it should be back down to normal. Okay, so this is a normal curve with it returning to close to what the fasting levels were within a couple of hours. Okay, so that's usually the 2-hour one is usually sufficient, but often they can also do the 3-hour one. So they do this for gestational diabetes. Now, if the patient is diabetic, you will have, so you have the fasting level here and you get that dose, and their levels will climb, and they will climb really high above 200, and they will stay above 200 at the 2-hour mark and at the 3-hour mark, and it will take a long time for them to come back down. So if they go up and stay up, basically that's diagnostic of diabetes. All right, let's talk a little bit about cystic fibrosis because it does affect the pancreas. It is a multi-organ disease. We talked about it in the lung chapter. So it affects the lung, liver, pancreas, and GI system. Everywhere where mucus is produced is affected by cystic fibrosis because they have really, really thick mucus production. And so many patients with cystic fibrosis also have pancreatic insufficiency. So they do not make enough of the digestive enzymes. So they're usually okay with their insulin and glucagon. They're not diabetics and stuff like that, but they need to be supplemented with digestive enzymes so that their food is broken down and they can absorb all their nutrients. Okay, so let's talk on that a little bit about malabsorption and maldigestion. So that's an inability of the body to absorb nutrients because you don't have enough of the digestive enzymes to break them down for you to be able to absorb it. So in malabsorption, you are actually breaking it down, you're just not absorbing it, and that's usually happening in the distal part of the digestive tract, so not at the beginning, towards the end as it reaches the end of the intestinal, small intestine, and then into going into the colon. But you basically, because of the inflammation that's present in most inflammatory bowel disease, the inflammation in the wall of the GI tract is preventing the absorption of the foods that have been broken down by the enzymes. So we have a lack of absorption, not a lack of digestion. Okay, and so think inflammatory bowel disease. We talked about in the GI chapter. You have your Crohn's disease, ulcerative colitis, celiac disease, and intestinal irritable bowel disorders and stuff like that. All of those. And then maldigestion involves the pancreas, and that one is where you have the lack of the digestive enzymes. It is in the proximal part of the digestive tract, so right after the stomach. So where you have the stomach dumps into the duodenum, and then you have the pancreas as the secretions and stuff, and if it's not operating properly and it's not adding those enzymes, then you're going to have, it's going to right off the bat have problems breaking down and making those big starch molecules and big protein molecules and big fat molecules and break them down into smaller ones. And so because it's not broken down, then you can't absorb it because it has to be broken down before you can absorb it. So signs and symptoms of malabsorption and maldigestion are anorexia, so not wanting to eat, weight loss, fatigue, shortness of breath, edema, weakness, tetany, so muscle contraction, convulsions, muscle contraction stuff. Dehydration, nutritional deficiencies, so you're lacking iron, you're lacking B12, you're lacking folate, you're lacking magnesium, all of those things. And of course, then that would lead to anemias and other things like that. Abdominal discomfort and distension, so you feel bloated all the time, you have lots of gas and stuff. Flatulence, so farting a lot. Gut rumbling, watery diarrhea. Steatorrhea, which is fat in stool, is because you're not breaking it down, so the fat's in stool, which gets really loose, bulky, offensive, really stinky, light-colored and greasy stools that are difficult to flush. So there you go, that's steatorrhea. So all of those are signs of malabsorption and maldigestion. And how do you diagnose pancreatic insufficiency? So for screening tests, you can do CBC, ferritin, folate, and B12 because those all look for anemia, and you would develop anemia if you had pancreatic insufficiency. And your chemistry panel, so you can look at your electrolytes and all of that. Those are quick screening tests. But just more specific tests, you would do a fecal fat and pancreatic elastase. Those are stool tests. And then the secretin cholecystokinin test is blood stimulation, kind of a little bit more invasive tests. Trypsin in stool and trypsinogen in blood, and chymotrypsin in stool. So those are all diagnostic tests of pancreatic insufficiency. There you go. And that is the end of the presentation. So again, thank you. I know this is a little bit lengthier as a chapter. If you have any questions, just let me know.